name is Hanali Kusain, a second-year medical student of Southwestern University, and I'm tasked to examine your heart today. Is that okay with you?
It's fine with me.
May I just confirm your name,
My name is Narlis Ali,
your birthday?
June 8, 1997.
Okay. These examinations involve me having to quick look into your hands, to your face, and your frontal chest. And also, it involves me having to listen to your pulse, feeling the rate, rhythm, and character. And also, these examinations having you to remove your upper garment. Are these okay with you?
Yes.
So let's start. Can you remove your shirt and tuck yourself on the couch?
Okay.
As Aziz is taking off his clothes, I'm looking for the signs of breathlessness, discomfort, and any form of deformability. Can you just pop yourself in it right here? Are you alright?
Yes.
Are you comfortable?
Yes.
Okay. Mr. Aziz here is exposed to 45 degrees. The whole of his chest is exposed, and I'm just going to observe Mr. Aziz and count his respiratory rate for 30 seconds. I'm also making general observation about his general condition. Okay, Mr. Aziz, I'm just gonna hold your hands. If you can turn them over to me. Okay, in here, I'm checking for tar staining, peripheral cyanosis, and clubbing. And now, I'm looking at your nail bed fluctuation, as this could be the first sign of clubbing. Okay, Mr. Aziz, I'm just gonna check for your pulse, and I'm feeling for the pulse rate, rhythm, and character. And if I suspect respiratory failure and carbon dioxide retention, I'm going to check for the carbon dioxide flood at this point. Okay, Mr. Aziz, can you bring your hand like this? Okay, that's grand. Just gonna quick look into your eyes. If you can look up for me. I'm just gonna pull the bottom of your eyelids down. Okay. And here, I'm looking for pale conjunctiva, suggestive of anemia. Okay, Mr. Aziz, can I ask you to open your mouth for me? Can you pop your tongue out? Can you lift it to the ceiling? Okay, pop it in and close your mouth. And here, I'm checking for central cyanosis by inspecting to the lips and tongue. Okay. After the general inspection, I will now move to examining your JVP. JVP, or your jugular venous pressure, is the highest oscillation point or meniscus of the jugular venous pulsation that is usually evident in a euvolemic patient. JVP measured at greater than 3 cm at your sternal angle or greater than 8 cm above your right atrium is considered as elevated or abnormal. As I begin my assessment, I would consider my patient volume status. If the patient is hypovolemic, I can anticipate that the JVP will be low. Likewise, if the patient is volume overload, I can anticipate that the JVP will be high. Are you comfortable?
Yes.
Do you have pain in your neck at all?
No.
Okay, can you turn to your left side? Okay, that's perfect. The right internal jugular vein runs between the two heads, your sternal head and clavicular head of your SCM up in front of your ear. So the two heads form the side of the small triangle with the clavicle making up the bottom edge. You should be able to feel a shallow defect formed by the borders of these landmarks. This usually makes it quite obvious. The internal jugular distension is not always an indicator of elevated CVP, as a value designed to prevent the retrograde flow of the blood can exist within this vessel, causing it to appear engorged even when the CVP is normal. It also makes several turns prior to connecting the central venous system and thus not a direct line with your right atrium. After identifying the highest pulsation, we are now ready to measure your right jugular vein, the jugular venous pressure, and in this case I will use the two tools, which is the rectangular cord and the ruler. Careful inspection of your anterior chest may reveal the location of your apical impulse, or the PMI. Shine a tangent-like apex to make these movements more visible, and plan to interspace. In this case, this is the right interspace. The second left interspace along the sternal border, and at the apex we will gonna use our palms or hold the fingertips flat obliquely against the chest wall. So the hips and lifts are sustained impulses that rhythmically lift your fingers, usually produced by an enlarged right or left ventricle. This is the padded area of your palm near the wrist, firmly on the chest, to check for buzzing or vibratory sensation caused by underlying turbulent flow. And if present, auscultate the same area for murmurs. Conversely, once the murmur is detected, it is easier to palpate for the thrill in the position that accentuates the murmur, such as the leaning forward position after detecting your aortic regurgitation. Represent the brief early pulsation of the left ventricle as it moves anteriorly during contraction and contacts the chest wall. In most examination, the apical impulse is the PMI. However, pathologic conditions such as the right ventricular hypertrophy, a dilated pulmonary artery, or an aortic aneurysm may produce a pulsation that is more prominent than the apex beat. So, we can ask again the patient to turn to the left side, that is called the lateral decubitus position. Okay, Mr. Aziz, again, can you turn to your left side? Just gonna assess for the apical impulse. For the auscultation, auscultate the heart with the stethoscope, with the patient's head and upper chest elevated to 30 degrees. We will start at either the base or your apex, listening with the diaphragm, then with the bell. Increments as needed. You can also auscultate your epigastric area. Alternatively, you can start at the base and insert your stethoscope to the apex. With your stethoscope in the second interspace, close the sternum, move along the left sternal border in each interspace from second through the fifth, then toward the apex. And I will gonna be examining your peripheral vascular system to detect diseases of your peripheral arteries and veins. And for today, I will just gonna be focusing on the arms and the legs of my patient. I will examine your arms. I will inspect the both arms from the fingertips to the shoulders. I will also note if there are any swelling, note for the venous pattern. I'll also note the color of the skin. Now, I'm gonna be palpating your radial pulse from both hands. This is actually your radial pulse from the thumb and the other one. Also, this is the radial pulse. And if I suspect for arterial insufficiency, I will palpate brachial pulse. This is the brachial pulse. And in the other hands, this is the brachial pulse. And also, I can climb at this higher point for the brachial pulse. And if I suspect arterial insufficiency in the arm or hand, I can palpate the ulnar pulse as well as the radial and brachial pulse. This is the ulnar pulse. The Allen's test compare the patency of the ulnar and your radial artery. It also ensures the patency of the ulnar artery before puncturing the radial artery for blood samples. The patient should rest with hands in the lap and palms up. We can ask the patient to make a tight fist with one hand. Then compress both the radial artery and ulnar arteries firmly between the thumbs and the fingers. And after 30 seconds, we can ask the patient to open the hands into a relaxed, slightly flexed position. The palm is pale. Release the pressure in your ulnar artery. If the ulnar artery is patent, the palm flushes within 3 to 5 seconds. The pharma flushing indicates a negative Allen's test, with pharma pallor indicates a positive Allen's test. Next, I will palpate the peripheral pulses. I will begin by palpating your popliteal pulse. The patient knee should be somewhat flexed with the legs relaxed. We can place our fingertips of both hands so that they will meet in the midline behind the knee and press them deeply into the popliteal fossa. The popliteal pulse is more difficult to find rather than the other pulses. It is deeper and feels more diffuse. Then next, I will gonna palpate your dorsalis pedis pulse. Palpate the dorsum of the foot and not the ankle. It is just lateral to the extensor tendon of the great toe. The DP artery may be congenitally absent or branch higher in the ankle. If you cannot feel a pulse, explore the dorsum of the foot more laterally. Absent pedal pulses with normal femoral and popliteal pulses raise the likelihood ratio of the pad to greater than 14. And lastly, I will gonna be palpating your posterior tibial pulse. Curve your fingertips behind and slightly below the medial malleolus of the ankle. This pulse may be hard to feel in a fat or edematous ankle. And after the examination, we should never forget to thank our patient. Thank you, Aziz, for being my patient. Samida.